Okay, thanks everybody. Well, it's a pleasure to be here. It's an honor, really. Good morning. I think that this lecture fits in very nicely with the series that's been done because Dr. Benjamin was here earlier, Dr. Mina Chung, our mentor from Cleveland Clinic, and they had very elegant talks about atrial fibrillation, and they covered a lot of background, primary prevention, secondary prevention, the genetic basis for AFib. And so this one is more of an interventional talk about having all that in place and then what we can do on the inside of the heart when we get there and what we're thinking about. So and then also some new options and new therapies. So hopefully it'll fit right in with what's been discussed. And then I also refer you to our Dr. Joe Decker's very nice presentation, which was a very nice overview of AFib ablation, which was earlier in the year as well. So hopefully this will be along the same lines, and it's an honor to be here. So, I think it's clear that atrial fibrillation management in the landscape is at a crossroads. So management has improved, and we understand now more about AFib origins. We understand how critical it is to target modifiable risk factors, and we have options that we talk to with our patients about tailored therapies, whether it's an ablation procedure, whether it's a device, whether it's antiarrhythmic drug therapy. There are new therapies, SGLT2 inhibitors, GLP-1 agonists, that will probably be a big part of the mix going forward. And so we can do more, and we understand that it's critical before the patient even gets to us in their at-risk stage of AFib, in their pre-AFib stage, before they develop AFib, to address these risk factors. What I want to also provide is some hope that once they develop AFib, the cat is not out of the bag. There's definitely therapies and things that we can do better than even before that can help with their AFib and help them manage their AFib in ways that were once thought not possible. So as part of my presentation today, it's really to provide context and deep dive about those interventional approaches and share our perspective as we see this information and the patient background and all the data that we get and how we manage it inside the EP lab. So if I get into little details about what we're doing, what type of ablation strategy and things like that, please bear with me. I'll try to make it as exciting as possible. So I really want to start a little backwards because this wouldn't be possible without the EP section and the EP group and the Heart Rhythm Science Center and the collaborative environment that we have in our institution across the service line with United and Mercy. We have great collaborative. I have great collaborative partners, and they are the reason I'm here to, doing a show and tell essentially of what we're able to do. We have cutting-edge clinical options. We have acquisition use of the latest technologies. We have a tremendous research capability. Our research scholars here, Kara and Miriam. Quality improvement. Dr. Moore has done a lot with Danielle in looking at how we're doing things, what we can improve with, and then research scholars and anticipated EP fellows in the future, which we're really excited about. And Dr. Pai has been heavily involved in creating that opportunity. And so every person from the APPs to the pacemaker nurse clinicians to the nurse clinicians to our whole section really has played a role. So I'm very grateful, and it's the reason why I come to work with a smile on my face every day. It's really great to work with everybody. So just to provide some historical perspective, Dr. Cox, Jim Cox, was a surgeon, is a surgeon from Duke and Washington University in St. Louis, and I was there in my residency. I always heard his name, but his contribution to this cannot be understated. He back in the late 1980s and early 1990s was developing a surgical approach to atrial fibrillation. And these are his diagrams. He taught surgeons to look at the atrium a little bit different, very similar to how we look at the left atrium, which I'll show you in images coming forward. And he was essentially, at that time, not only addressing AFib, but thinking about, this was an article that he published in 1995, thinking about how he can modify his initial approach to treat atypical flutter and other variants that seemed to arise after the initial procedure. And his approach was a cut and sew method. So he would cut and sew the tissue together, and these were legitimate lines of block. So he was essentially creating a maze, but noticeably, the pulmonary veins were excluded from the left atrium, which was a critical part of his procedure. So he's essentially, maybe he didn't know it at the time, addressing the triggers as well as the substrate for AFib. And it wasn't until the late 90s when Hassager and Jace in Bordeaux published this seminal work where they identified the electrical triggers for AFib, which had previously not been thought to be a possibility. And that work set the stage for everything we do today, because we know that those triggers mainly come from the pulmonary veins. But there are triggers outside of those areas as well, sometimes from the SVC, sometimes from other parts of the atrium. But that is essentially what led to the race to develop ways to ablate around the pulmonary veins and isolate those structures, which Dr. Cox was already doing. And at the time that Hassager and Jace made that observation, the seminal discovery, there wasn't anything but a plastic catheter with some electrodes on it through which they were obtaining electrograms. And so, the progression from that point onward is based on, the pioneering work of giants in our field, Andre and Natali and others, who then started to work in industry to develop ways in which we took that understanding and made it into a procedure today where pulmonary vein isolation is the basis for our AFib ablation. It's not in itself the main, the only thing that we need to do, and we'll talk more about that, but it is the foundation for what we do. And here I'm showing you images of how we get into the left atrium. Here's a transeptal puncture. Nowadays we have tremendous capability with imaging inside the lab. I can put an ICE catheter up, intracardiac echo, and I can just scan around the left atrium, and an AI software from the mapping system creates a three-dimensional reconstruction of the left atrium. And then I can go in there and create a matrix and do my work. So electroanatomic mapping, imaging, catheter form factors, ablation technology has all been advancing over the decades, and I'll spare you all that work that happened in the meantime, but you can see it took many companies, many systems, many basically leaps to get to where we are in terms of cardiac ablation. And the mapping system is critically important to our work. So we have this, based on magnetic fields and sensors around the patient on the table. We can then move our catheters, and I passed a catheter around for you. It has a magnetic sensor on it. We can create a geometry of the left atrium just by roving that catheter around inside the heart. And we understand not just the geometry, but many aspects of that left atrium. We understand the voltage, the scarring, oftentimes something that you can't appreciate on MRI even. It has that degree of fidelity. And we understand activation if we're mapping an arrhythmia, where it's coming through, how it's propagating. And this catheter in particular has been our workforce. This is what's called a contact sense catheter. So it has a little contact force sensor on the tip. It gives me a directionality as well, a force number that I can use to guide, so I know that I'm making contact when I'm making lesions. We all know that this is what AFib looks like on the surface EKG at the top here. This is what AFib looks like inside a pulmonary vein with a catheter positioned there. And this is what AFib looks like inside the left atrium. And this is a patient who comes to us for an AFib ablation. By the time we're done and we've isolated the pulmonary veins with our catheters, this is what we hope to restore, normal sinus rhythm. And this is what it looks like with intracardiac electrograms. So we've also made progress in understanding who benefits and who doesn't. Patients with symptoms, quality of life is critically important. Patients with LV dysfunction and congestive heart failure, which can be the chicken and the egg situation with AFib. Younger patients to prevent comorbidity, antiarrhythmic drug therapy, patients who are on drugs but are having side effects, and patients with bradycardia who may not want to defer a pacemaker. These are patients we're pretty aggressive with when it comes to ablation strategies. And there's data to support that. Early rhythm control, whether it's through an antiarrhythmic medication or through an ablation procedure, has been shown to reduce the risk of cardiovascular heart failure, stroke, hospitalizations. So this was published in the New England Journal from the East AFNet4 trial investigators. So, and then there's, of course, good data that was building with Castle AF and other studies with heart failure. So we were getting to this point where in 2023, the guidelines came out and said, catheter ablation for AFib as a first-line therapy in select patients is a good option, class 1A. And that's great. Okay. I think I'll give you your time back. It'll be about 35 minutes. I think we're done here. We've solved AFib. No, unfortunately, that's not the case. There is this case of recurrent atrial arrhythmias. Like we get into the heart, and we know that, like from the previous presentations, there's so much to AFib that can be done before the patient sees us, right? And this presentation is assuming that all of those risk factors, modifiable risk factors, understanding of AFib as it pertains to a particular patient, that's being addressed. And then we do an ablation. What are the barriers to the long-term success of that patient and the recovery? Well, it turns out we can ablate around the pulmonary veins, but sometimes there can be recovery of connection between the left atrium and the pulmonary veins. It turns out there are arrhythmia variants that we also need to target, atypical atrial flutter, for example, atrial tachycardia, other types of tachycardias. There's substrate differences between the patients we see in the lab. I'll show you examples of this. So I look at it as terms of phenotypes. You know, Dr. Chung gave this great talk about genetics of this. It really is true. Is there a specific phenotype that we see that is associated with tachy-mediated cardiomyopathy, or the phenotype associated with HFpEF? And so, you know, if you look at it, start to looking at it that way, you can try to also work backwards to the genetics or forward to their outcomes related to certain ablation strategies. And then AFib progression. We know that if we do a perfect pulmonary vein isolation or perfect ablation, ablating all these targets, maybe in 5 to 10 years, they still come back with AFib. And I'll talk more about that in a second. But this is an example of a patient that we go in and we've done a prior ablation, and this is a look at the right superior pulmonary vein. And you can see that now it should be red. Red is dead after a previous ablation. And there's actually voltage there. So it is reconnected because the tissue is healed from the prior ablation. And here's an electrogram evidence of what's triggering the AFib. The patient is in sinus rhythm for a couple beats, and there's an electrical signal that initiates from the vein, sorry about that, and then triggers AFib in the pulmonary vein. And this is what this signal does. And that AFib translates to AFib in the rest of the heart because that vein is connected to the rest of the atrium. So once we restore isolation of that vein, if this is their predominant driver of AFib, they should do very well. But they needed a second procedure, you know, to accomplish this. Ideally, we want to be one and done. And if you ask, well, what is the durability of pulmonary vein isolation in patients? You know, we don't always get this data because we don't always routinely go back into the left atrium after an ablation and just check to see if we did this, you know, 3 months later, 6 months later. That type of study wouldn't be approved in the United States. But historically, it has been done, and I call this the Liverpool study. This was a patient, this was in Liverpool, and these were patients that had persistent AFib, so they had significant left atrial scar. And when they went back, they found that at least one pulmonary vein reconnected in at least 75% of patients. And these patients had significant LA scarring. They did find that radio frequency was slightly better than cryoballoon ablations. But this was a little bit disappointing, right? And maybe if you're getting success rates of 70%, 80% freedom from AFib in 1 year, it begs the question, well, how is it possible that so many veins recovered? Well, maybe in in paroxysmal AFib, they don't recover like they do in persistent AFib. Well, not the case. Actually, they highlighted various studies in this paper where there was anywhere from 7% recovery reconnection rate in the pulmonary veins to 59% at various times. And they used various really good ablation strategies that up to this point had been our go-to strategies. Lesion index, contact force, things that we use very readily in the lab to make sure we're delivering good lesions. So it was a little disappointing. You know, there's definitely room for improvement. And then arrhythmia types. You know, when we're in the left atrium or the right atrium or in a patient doing these procedures, we're always looking for other triggers. You know, are there triggers outside the pulmonary veins, like from the superior vena cava, as in this particular example? So this is the SVC. There's a firing from the SVC that we need to isolate. You know, Jason Hasegair identified that very early on. Even Cox identified that maybe I need to do a maze in the right atrium to target some of those triggers, although he was a little bit worried because he might affecting the sinus node function in that area. There are PACs or other tachycardias, and then there are these other arrhythmias that come about from the left atrium we call atypical flutters. These are different from the typical flutter in the right atrium, which is around the tricuspid valve and typically counterclockwise. These are areas that are around scar. You remember how I showed you that atrium is, I'll show you more, a purple atrium is healthy tissue. This atrium is very diseased. You can see that there's very little purple. There's a lot of green, which is this intermediate voltage, and red, which is a lot of significant scar. And this is not something you would appreciate on an MRI, but you might notice it, you might assume it if the left atrium is very enlarged or functionally impaired. And so these patients are prone to having roof flutter. Let's say they can have a circuit go on over the roof, or they can go have a circuit around the mitral valve, or they can have a micro reentry circuit around one of those areas of scar. And they may have other drivers. And I use this symbol to signify rotors or drivers. There's this other concept, which we'll get to, that may signify other areas electrically that we need to target to improve the outcomes in those patients. So this is also what we're looking for to improve their outcomes and trying to target those areas as well. And then what if I told you this is a healthy left atrium, right? This is purple, and that is a diseased left atrium. But what if I told you that this is the patient who had cardiomyopathy and tachycardia cardiomyopathy and was sent to us with persistent AFib, and that is the patient that you saw 20% AFib on their ZEO, and they're sent to us, and in the lab we find this. This type of discordance is not unusual. We get into the left atrium and we're like, this is not paroxysmal AFib. This is looking like a very persistent or advanced AFib substrate. And this should be persistent AFib, but this patient's left atrium is great. So we're always happy to see this. And so this is the critical aspect of early referral, regardless of AFib burden, because the process of atrial myopathy and AFib progression, electrical, structural remodeling, can be taking place that's somewhat discordant from the amount of AFib that you're seeing clinically. And so that's very important to remember. And we'd much rather ablate the healthy atrium than the atrium because our success is going to be higher. And so we know a lot about the patients going into a procedure. We know the clinical impact that AFib is having on their life. We know their imaging data and functional data on their atrium. And then intra-procedurally, we get a ton of information. We have hemodynamic data, what their left atrial pressure is, what the volume is based on our map, what the fibrosis substrate is, what the electrical substrate, whether they have other arrhythmias, and whether they have other tachycardias that could be triggering the AFib. So these are aspects that we're trying to address at the time of the ablation in addition to that. And if I see someone with a high left atrial pressure when I'm in there, almost certainly we're trying to discharge those patients on aldosterone antagonist, SGLT2 inhibitors, and so forth, because we're trying to change that secondary prevention aspect so that they don't come back with AFib, even after the best ablation that we can do. And up to this point, the ablation that we can do, I call it the fire and ice saga because it's really radio frequency and cryoballoons. So and these there are we worry about these types of events every time we do a procedure. We do our best to avoid them: cardioembolic events, steam pops, perforation leading to effusion, pulmonary vein stenosis from ablating too far into the veins, phrenic nerve paralysis or elevated hemidiaphragm. And then the feared complication, fortunately, which doesn't happen very often anymore, but still you think about, you worry about as you're thinking about these patients after you've done a procedure, esophageal fistula or esophageal pericardial fistula. And these were because these were thermal energy sources, right? And there's collateral injury. So when we're ablating inside the heart, we're also targeting inadvertently structures around the heart, like the esophagus or the phrenic nerve and so forth. So this is a busy slide, but I want you to stay with me because this is an important slide for definitions and lingo. So like I said, AFib ablation strategies, now you can tell there's an infinite number of ablation strategies when I go into a left atrium for a patient. Because based on what I see, is it a healthy atrium or not? Are they in sinus rhythm or not? I can do various things. I can cardiovert them and then ablate them. I can ablate them, wait till they convert on their own. I can do the PVs ice only. I can do PVs versus plus scarred areas. I can do PVs versus any inducible arrhythmia. I can do a box lesion set on the posterior wall. I can do lines all over, roof lines, mitral line, ablate in the right atrium, SVC ablation. We in Cleveland, where many of us trained, we would see a lot of patients. We trained kind of with the Andrea Natali technique, which is basically eliminate most of the electrograms in the left atrium. So if any of those patients came back for an AFib ablation, we were always worried because we knew for sure we'd go into the left atrium and there would be no signals in the left atrium. There'd be nothing left to ablate. And we're like, how are they still in AFib if there's no left atrial signals? Maybe it's the right atrial driver, maybe there's something else. And even that type of ablation has led to a separate pathophysiology called stiff left atrial syndrome, where you can have too many ablations resulting in too little electrical contraction of the left atrium. And ideally, most of us feel that there's probably this sweet spot. We need to ablate at a certain amount where we need to prevent AFib from coming back, but our lines and other things that we're doing shouldn't cause more atrial flutter or tachycardias that we need to then address at a different procedure. And understanding the best strategy will help us move the needle. But we can all agree that it would be nice to ablate normal atrium, and it would be nice to potentially ablate with something other than RF and cryo. So that brings us to, what do plasmids, potatoes, and atrial tissue have in common? And many of you are basic science backgrounds. You've worked in the lab with bacterial cells, and you've electroporated them so they take up DNA. Believe it or not, in Idaho, they do this with potatoes. They shock potatoes with an electric field there's maybe a antimicrobial effect. They make them more porous. Maybe the texture is better for your chips. It turns out that this technology can be applied to the left atrium, electroporation. So this is what we're calling now pulsed field ablation, and it's a dramatic shift in how we do these procedures. So this is a non-thermal energy that limits collateral damage. It's a DC power supply to charge capacitors, discharge your pulse with the help of a high voltage switch, and it's delivered between 2 or more electrodes, creating an electric field. And it's over the phase of a nano or millisecond range, and the orientation can be monopolar, bipolar, or omnipolar, depending on a catheter form factor that you're using. And if you want to know any more physics about it, just ask Dr. Olson. I'm sure he'll be happy to go through all the engineering aspects with it for you. But think about it this way. We want to ablate cardiac tissue so it doesn't recover. So we want to do irreversible electroporation. We don't want to injure tissues around it to the point where there's thermal injury, and we don't want the reconnection to occur that we saw with our current therapies. So this is the irreversible electroporation that requires a certain amount of electrical field strength and pulse duration. And fortuitously, the amount of energy that it takes to do irreversible electroporation in cardiac tissue is less than the amount of energy it takes to injure the esophagus or the phrenic nerve or the surrounding structures. So it's often that now we have something more selective, cardioselective, so we don't get potentially the pulmonary vein stenosis or the phrenic nerve injury that's permanent. I'll come to that again, and esophageal injury for sure. Then I can sleep better at night. I'm not going to worry about esophageal atrial fistula, esophageal pericardial fistulas. So that's really cool. And so I appreciate these slides from our industry team members. You know, Medtronic, this is an example of this permeabilization with electroporation of a cell membrane that triggers this cell death mechanism, which is an apoptotic mechanism. And here they're describing the catheter delivering sub-second bursts of high voltage direct current through the electrodes, creating these pores that are above the tissue-specific threshold, these nanopore formation that then trigger this cell death mechanism that has to do with calcium, disruption of calcium homeostasis, disruption of ATP, creation of reactive oxidative species, and membrane instability. And very importantly, this type of cell death is very different than radiofrequency and cryo. Those were more coagulative necrosis due to lack of blood supply, direct cell injury. This is an apoptotic necrosis process that may help to preserve the underlying architecture of the tissue and may be less inflammatory as well. We'll see. So these are the form factors that are in development, some of which we're using currently, some of which are soon to come to us. But these are the ways that we can apply this electric field inside the heart. So we have the pentaspline catheter here, circular catheter, a sphere catheter. We'll get into more details about that. But the form factor is very important because it is what allows you to deliver this energy to the tissue, and you want to do it in a safe way where the catheter is not causing any harm to the patient. The directionality matters, and it helps us to derive the best strategy. You know, there are some catheters here that are meant for the pulmonary veins, to isolate the pulmonary veins. But as you know, we oftentimes have to ablate outside the pulmonary veins. So there are other catheters that are maybe better suited to do focal types of ablation outside the pulmonary veins. But we can't pull out 5 catheters for a particular procedure. So you know, the EP community has had very interesting ways to manage this various form factor issue with different technologies. And we'll talk about that as well. This was a really cool article because it shows modeling, computer modeling of what the electrical field density looks like with various form factors. And so when we're ablating with a sphere catheter or with a pentaspline catheter, these are with one single application of energy, this is the type of effect we could have on tissue. So if it's a larger catheter, it's a broader effect, and it could be good enough to ablate the pulmonary veins in one lesion or one application. It's no longer, it's PFA. The other thing to keep in mind is histologically, like there is a difference, right? We talked about that. So this was a very early study that looked at comparing the depth of lesions. And depth of lesions is very important to us because we want to make transmural lesions that don't recover. So they actually in an animal model, looked at radiofrequency energy versus pulse field directly, and they didn't find, at least with this particular catheter, there was significant depth differences. But when they stacked lesions on top of each other, either RF on top of the same PF lesions or PF on top of the RF, they did get increased depth. And the part here, the central zone, is the coagulative necrosis that's typically associated with radiofrequency energy. And the dark zone underneath is the area that's associated with apoptosis. And so you can imagine that this could have revolutionary impacts on not only atrial arrhythmias, but ventricular arrhythmias in the future as well, which we anticipate coming very soon. So let the race begin. We have all the major players: Medtronic, Boston Scientific, Johnson & Johnson, Abbott Vascular, and others that are creating this one. Dr. Zakib and I call it the Death Star. It's made by a company called Cardima. Oh, sorry, and this is called the Globe catheter. So this is a true one-shot ablation. You think of that catheter in the left atrium, you put it up against a vein and you deliver one pulse, you're probably isolating that pulmonary vein. And there's others. This is the Sphere 9 from FARA. This is the Pendospline catheter from Boston Scientific. This is the extended loop catheter. Don't call it a lasso catheter, but Biosense Webster. And there are other catheters coming out, Omnipulse and Dual Energy. So you can see the various form factors, the various companies. It's really a space race to get to the optimal tools that you need to do this procedure. Our first exposure to this, Dr. Melby and I, very grateful that we were part of this study called the ADMIRE study. So this was the pivotal study. This was a couple years ago now with the Biosense Webster Varipulse catheter, which is that extended loop catheter. And we were in this study, and it was really to make sure that this was a safe and effective strategy. And I just want to point out that it performed very well, but there were some limitations, right? You're like, well, why is there 75% success, freedom from AFib or atrial arrhythmias in 1 year? Why isn't that needle changing? And this seems to be a common theme. How can we get that to 90% or 95%? Remember, we had 93% with our RF ablation. And then, but it did show that this was a safe catheter. It was feasible. It was efficient. And I'll tell you, anecdotally, from the first time I used it, the signals just melt away. Like you apply PF, and then there's no signals in the pulmonary vein, and you're like, this is amazing. You spend years learning how to get rid of these things. It's like a battle to sometimes get rid of these ablations with RF and the signals. But we know that sometimes that can come back, right? It's not oftentimes the most durable. And so that is a work in progress. And this is why this story is very helpful. This is the Farapulse story with Boston Scientific. And they founded this company in 2012. Boston Scientific brought it along and then acquired it. And there was a time where they actually almost threw this technology away because they realized that an animal model is not akin to a human model in terms of PFA. And they weren't using the right waveforms. And so they had to optimize whether it's a monophasic or biphasic or optimized biphasic. It's important to recognize there's a lot they can change under the hood to get different depths. And remember, I showed you that depth that was maybe good, but I anticipate, and if you talk to these engineers, that with further tooling of this technology, we will be able to get depth just with PF that will be pretty remarkable. And that would be amazing, not just for atrial arrhythmias, for ventricular arrhythmias as well. So they came out, and this is the catheter that has really taken off. This is that Pendospline catheter, and now there's more than 500,000 cases nationwide, more so worldwide. So it has really been a boon for them, and really brought PFA to the forefront. And it was after FDA approval, that was the first catheter that we acquired and used in our arsenal. And this was their publication in the New England Journal, where they compared their technology to conventional thermal ablation, and they showed that it was non-inferior to procedure failure, documented atrial arrhythmia, and antiarrhythmic drug use, or repeat ablation or cardioversion in 1 year. There were notably less phrenic nerve injury, pulmonary vein stenosis, as you would expect, but there were 2 pericardial effusions and 1 related death to emergent sternotomy, and 10 days later that patient died. So there are issues, and this is a little different catheter design, right? It's over a wire that we have to go into the pulmonary veins with, and more fluoroscopy, other things that we've been trying to get away from. So it was very interesting, and it's still probably the workhorse of the majority of people around the country that use this because it's pretty effective. I call it the Cybertruck of PFA. This is probably, if you said, what is the this is probably the Ferrari of PFA. This one is one we were lucky to use early. It's called the FHRS system, and it's a focal pulmonary vein isolation catheter and atypical flutter ablation catheter. So you can apply it to repeat ablations, you can apply it to atypical flutters. But they did a really interesting study. They looked at persistent AFib patients, and they wanted to look at different pulse waveforms, so what's under the hood. They also had many operators. Much of this was done in Eastern Europe, where they could go back and remap the same patients at 75 days. Remember, we wouldn't do that here necessarily. And they wanted to see if they had durability of their pulmonary vein isolation. They also looked at brain MRIs, cardiac CT, Holter monitoring, and they wanted to make sure that they got acute and durable pulmonary vein isolation and those linear lesions, durabilities, and freedom from AFib. And so this is what this catheter looks like. And you can see that the depth of the ablation, and this is a really special catheter in another sense, is that it can apply radiofrequency energy as well as pulse field energy from the same catheter. And the same catheter is the one that I use, we would use for mapping purposes in the left atrium, the right atrium. So it's like one catheter that basically does Swiss Army knife and does everything in the left atrium. And the depth is pretty good, the width is pretty good. And these were some of the, and I'll kind of go through this quickly because you would expect that initially they would have 100% success in the procedure of isolating the pulmonary veins or creating a mitral isthmus line or a roof line. And there was. And there was very few complications. And they were very fast, efficient procedure times. But they did find that the pulse 3 waveform was the one that was least likely to reconnect during the procedure if they assessed reconnection. And that's also the waveform that also had the least likelihood of pulmonary vein reconnection at a few months after. But look at these pulmonary vein durability numbers, 97%, 90%. That's been reproduced with other technologies like Omnipulse, 85%, with Farapulse in the 90% range. So that is really interesting, right? Because remember the Liverpool study, 50% in persistent AFib or 70, 80% otherwise in paroxysmal AFib. This is now maybe moving the needle, right? We're getting more durable lesions, and it's not relevant just for the pulmonary veins, but it's for all the lesions that we put in the left atrium. So this was really exciting to see this. And here's your AI, the necessary AI moment of any presentation now. So I asked Google, what are the FDA-approved PFA technologies for AFib? These are the technology, and a lot of credit to Dr. Abdelhadi and Dr. Katsianis. We have the fortune to use the most commonly available tools, and we were one of the first to use this Medtronic Affera, the focal catheter that I just spoke about. And really the only one that we don't have is the one we didn't want. so we have these tools, and we have the ability to really advance the science and elevate our space in this because we're using those in ways and trying to advance the best practices and best use of these technologies. So are there pitfalls? And I'll talk about pitfalls while Dr. Decker here does a beautiful map of the left atrium as we're talking. Let's see if this is playing. And so there are pitfalls. So one of those pitfalls, it seems to be playing, but it's not playing. But yeah, it's kind of playing in fragments. But he's creating a map with the Sphere 9 catheter in the left atrium of the voltage, of the geometry of the left atrium. Yes, if you use PFA near a coronary artery, you can have vasospasm. It has vagal effects, so we have to use medications to counter that, atropine, glycopyrrolate. We have over-the-wire systems, increased fluoroscopy, so kind of going backward a little bit. We don't have the contact force sensors or lesion index that we once used with RF. We don't want to ablate near the conduction system with PFA. We could take out the conduction system. We need to use general anesthesia for most of these tools, maybe not in future for other tools. Embolic events, we use large sheaths sometimes with these catheters, and we're changing catheters all the time. So we want to prevent air embolism, embolic events from the catheter. There are device-device interactions that we need to be aware of. And then there's an off-label use that's in the EP community where they're doing all kinds of things, ablations with these catheters. And I have a name for that. I don't know if it'll catch on, form factor target or form factor substrate mismatch. So there's a lot of things going on that will be interesting. And our own Mike Downey and Carol Abdel-Sayed, our research scholar and future EP fellow, they published this paper based on what we know were pacemaker and defibrillator interactions with PFA applied during a procedure. And this was one of the earliest publications of what PFA looks like from the perspective of a device that was published in a paper. And we found that oftentimes we can inhibit or create a loss of capture even if we're remote from the tissue contact with the lead so that it means that there's a halo effect from the pulse field that might affect tissue far away from it. So it's one of those things that we are learning about how to use this technology. But let me just show you a few cases here that might be very illustrative of what we're talking about. So this is a patient with paroxysmal AFib, severe COPD, and presents for ablation. And I used this case I did on Friday with the Varipulse catheter. And it had come a long way since the Admire study. I can actually use the electrodes that I want to ablate, and ultimately I want to create a pulmonary vein isolation. This is a pretty healthy left atrium, and ultimately we used the LAAC, the extended loop catheter, to create a great pulmonary vein isolation. This is great. Hopefully that will be very durable, and this patient should do very well, provided that those pulmonary veins do not reconnect. This is the type of case, though, that gave me real confidence and this is our second case that we did with the FHRS system. This particular, and you're like, well, when you're using a new technology, how is it going to work? You want to make sure the patient's safe. But we had a patient, and this patient's story probably follows many stories of your patients. She had AFib diagnosed in 2010. She had an ablation in 2016. She had recurrent arrhythmia. She was put on sotalol. She has multiple AFib risk factors that need to be managed. She was transitioned to an alternate antiarrhythmic therapy. She had recurrent atypical flutter. She had, this EKG. It's not sinus tachycardia. Every time you get this EKG from the ER, it says sinus tachycardia. No, this is atypical flutter, most likely. And then she had ablation with the latest technologies, multiple ablations, even 2 in the last year. And these are limited by the fact that some areas of the tissue are very thick, and it's hard to get energy delivery. So this is a person that's had multiple ablations. You can see a roof line and reconnection. There's reconnection in those areas, even though there were multiple lesions placed into those areas. And so with the limitations, it didn't matter, multiple operators, best RF technology, we couldn't get durable roof isolation or pulmonary vein isolation. So we wanted to put this to the test with the FHRS system and see first if the mapping system would be sufficient to identify the circuit, which it did. You can see the circuit is right here on the roof. So this is the left atrium tilted up a little bit. You see the roof here. This is the Sphere 9 catheter there. And you see the patient is in atrial flutter right here on their EKG. And you're going to see right now the application of the PFA. And then, let's see, I'll give it a few seconds here. And we'll see with one application. Now, historically, there's the PFA application right here, right where the catheter is located, right in that critical isthmus of this flutter. And you see here, the patient's in sinus rhythm. So we terminated that arrhythmia with one application. But, it could still come back. But because the esophagus is here, and because of our inability to ablate deeper and wider with RF because of the issue with collateral injury, this is no longer a problem. So you can see that here's the circuit, that was the ablation, and then this is the ultimate result. We can put in multiple PF applications to make sure that this area does not recover. And this arrhythmia is very unlikely to come back, even though it kept coming back with previous ablations. So now people are out there using the other form factors, for example, to do atypical flutter. So this is a recent publication from Cleveland Clinic where they looked at using the Varipulse catheter to do these atypical flutters. And this is a recent publication from Andre Natali, where he's also using the FARADrive catheter to isolate the left atrial appendage, isolate the coronary sinus, isolate different areas, the mitral isthmus, but maybe not with the right form factor. And you can see with his results, he brought these patients back for a Watchman implant, so he was able to remap after the initial ablation, and he showed that there's very little durability in their ability to isolate those structures with that catheter. And that's why we've coined this term mismatch between the substrate. This is our research scholar Miriam's project that she's been working on, and showing that our experience with the Affera catheter, which is a focal form factor, and ablating those atypical flutters. And we've really found that this particular technology shines in those particular areas. So we've had very good success and long-term success with this catheter, and this is yet to be submitted, but it's soon to be submitted for publication. So the question is, does this move the needle? I'm going to show you a few cases that I think will be really helpful to understand what we couldn't do and what we can do now. So this is a gentleman, 49 years old, who was in the hospital in May here in Abbott. He was transferred here for cardiogenic shock. He has diabetes, history of embolic CVA. He's only 49 years old. History of alcohol abuse. He was admitted with an EF 15 to 20%, left ventricular end-diastolic diameter is 6.5. And Allison, who was taking care of this patient, Allison saw our wonderful APP, she had identified somewhere in the chart, there was this mention with the prior ablations, he had pulmonary vein stenosis. And indeed, he had a CT scan, and then this is when we took him to the lab. He had a map of the left atrium, and you can see the left superior pulmonary vein is gone. It's completely occluded. So he had had 3 prior RF ablations up north, and then the left superior pulmonary vein was ablated, and the left inferior pulmonary vein is quite stenosed. And notice there's also recovery inside those veins. So even with the prior ablation, he didn't really have durable pulmonary vein isolation. So this is not a patient I can bring back with RF and ablate those areas. So we brought him back with a PFA and re-isolated those pulmonary veins with less concern for pulmonary vein stenosis. And he had a mitral isthmus flutter, which we did with RFA and PFA on that mitral isthmus and a roof line. And I just looked him up on Sunday, yesterday. His EF is 47%, no symptoms. This was a person that they were really considering LVAD because he was not able to get out of the ICU. And he's doing pretty well. So at least we've bought some time, and no plans for even ICD now, given his EF has recovered. This is a patient who had Dr. Melby and I take care of, had multiple prior complex ablations, and a pacemaker for sinus node dysfunction, remains on antiarrhythmic therapy, and presents for repeat ablation. And this particular individual had electrical signals after everything else was ablated. The left atrium has been ablated beautifully with prior ablations, but she still had atrial arrhythmias, and it was coming from a signal located in the SVC. And with one PFA application in the SVC and isolation of the SVC, we were able to terminate her arrhythmia to sinus, and she's had very little recurrence afterwards. And SVC isolation, without the worry of SVC stenosis or phrenic nerve injury, is much more amenable to PFA than it was to RFA, although we do need to make sure that we don't affect the sinus node. In that case, she has a pacemaker already for pre-existing sinus node dysfunction. This is a patient with, and apologize for the initials, they're the same initials, but different people. So lamin A, a gene-related potentially cardiomyopathy. And this is an important point. Genetic testing for patients with cardiomyopathy or tachypneic cardiomyopathy that may lamin A, titin gene mutations, these are often associated with atrial arrhythmias. So I had done a previous ablation for her for AFib and atrial flutter, and she had done very well, but she continued to have these PACs that came from the right atrium right near where the phrenic nerve coursed. And so I couldn't ablate that with radiofrequency. So I brought her back with a FARA, with a focal PFA, and then you can see she's having bigeminal PACs here. And we get to that one spot, a PF application, she's in sinus rhythm, she's no longer bigeminal, significant improvement in her quality of life. So, multiple examples. This is a young woman with a crazy substrate in the right atrium where there's extensive scars. She kept coming in with this tachycardia, this atrial flutter. And Dr. Olson and I had the pleasure of taking care of her along with the team, and she kept going into this tachycardia no matter what we did. She had 2 prior RF ablations. And this is not your standard typical cavo-tricuspid isthmus flutter. This is a right atrial flutter that percolates through that scar. If she had an MRI that showed RA at the upper limit of normal but could not detect the fibrosis. But you can see on our electroanatomic map how much red there is in the right atrium. And so with PFA, we're able to ablate all the way through that scar, essentially homogenize it and connect it to the cavo-tricuspid isthmus line and terminate arrhythmia. And she's been arrhythmia-free after that last ablation with PFA. So the application potential for PFA is pretty limitless. And when you combine it with things like Dr. Melby is doing with identifying those drivers that exist outside the pulmonary vein, and other companies are looking at that too, but my money is on Dr. Melby more than it is on AI. But Cortex, Volta Medical, people are looking for those other sites. And if you add PFA to that ability to ablate those areas, we should see the marriage result in more success. And these are studies that are coming up at our institution. There's the Omnipulse BioSense study. There's the driver study, that is the advanced AFib study. Dr. Moore and Dr. Kruger have all of our PFA patients in a registry. And then the Sphere 360 study, this is going to be their one-shot catheter. We have that coming up next year along with post-approval registry. So a lot of interesting work with PFA that's going on. Great. I think we're done. No, not. But doctor, do I need to stay on my blood thinner after the ablation, right? So this comes up all the time, right? And we know that thanks to Dr. Van Tassel and Dr. Hauser, who developed the Watchman device, this has been a great alternative for patients who have bleeding issues. Well, our colleagues at the Cleveland Clinic were very thoughtful and along with Boston Scientific, did a study looking at AFib ablation plus Watchman, either sequentially or concomitantly, versus oral anticoagulation. And this is not your typical Watchman patient. This is not the patient that has a high HAS-BLED score or has had bleeding issues. This is the patient that just has a moderate to high risk of stroke related to their CHA2DS2-VASc VAS score. And they wanted to see if AFib ablation and Watchman is either sequentially or concomitant would be similar to AFib ablation with oral anticoagulation. And this was studied for expanded indication. They wanted to expand the indication for Watchman as a first-line therapy against oral anticoagulations. And it just so turned out that 95% of the patients in the study were on DOAC. So it was really a comparison of Watchman against Eliquis and Xarelto after an AFib ablation. And they looked at primary efficacy endpoint of stroke, all-cause mortality, and systemic embolism. And they looked at safety endpoints, which was non-procedural bleeding, both major and minor bleeding. And this was published in the New England Journal last year, really a landmark study, left atrial appendage closure after ablation for AFib, and it has basically set the stage for us to do this procedure concomitantly. And these are protocol-mandated regimens, so the control group got DOAC or warfarin. The device group patients were prescribed a 3-month course of DOAC or warfarin after the ablation and then aspirin. And then they compared the use of oral anticoagulation. So there were 1,710 patients that were randomized almost evenly between the ablation plus Watchman arm versus the ablation plus oral anticoagulation with 3 years of follow-up, very similar baseline demographics. And this showed that there was a non-inferiority that was met when using the Watchman in comparison to using oral anticoagulation. And the safety, there was similar events of all-cause stroke and ischemic stroke in 3 years of follow-up, which is pretty amazing to see. And the superiority when it comes to safety was met because of non-severe bleeding, essentially. So any bleeding that would result in some face-to-face consultation. And that's a common reason that people don't want to be on blood thinners, right? They want to not have bruising. They want to be able to do lifestyle. In Minnesota, they want to be able to play hockey, right? So there were those things that probably made it superior because the bleeding risk was less in the patients with Watchman compared to oral anticoagulation. And so it's driven by clinically relevant non-major bleeding. So CMS looked at this and they approved the code, and this is why we're now able to do concomitant AFib and Watchman procedures at the same time. And Dr. Hamid and her team has been very helpful. We do the TE up front, we do the ablation, they come back in, they help us put in the Watchman, and we'll talk about some of the workflows. Now this is something that Dan showed me afterwards that was published in Heart Rhythm, and this is a use of a pendospline catheter near a Watchman device in a potato model. So it takes us full circle, right? And this is what I told Dad. This is why I do the ablation first, then I put in the Watchman. So I avoid that arcing that can occur. But it's somewhat being facetious, but it's true. Now we can do this procedure. This was a procedure time for PFA in the Biosense time. So the procedure time for PVI was about 81 minutes. These are, so far our procedure times with concomitant. We can do basically the Watchman and the pulse field ablation in a very similar time, slightly longer, about procedure time about 112 minutes, with safety, similar safety and efficacy in long term. And it does require a workflow to get this right. It's a lot of moving parts. So we oftentimes ablate the right-sided veins first, then the left side. We plan the transeptal puncture based on the trajectory for implanting the left atrial appendage occlusion device. We use a TruSteer deflectable sheath that has been an improvement for the Watchman implant. We look for ACT goals that are maybe higher when we do the PFA ablation. And then Drs. Miriam and Tesfa, along with Dr. Hamid under her direction, are looking at reviewing dimensions. And we kind of plan to maybe even upsize the device to prevent that long-term peri-device leak that can form around that device. So what is state of the art at October 6th at 7:50 a.m. Central Standard Time? Because it could change in 10 minutes. But the right target, the right energy, and the right form factor are critical. And we've taken a PFA dominant approach with RFA near vessels and conduction system. We understand more about the atrial fibrillation phenotype, the clinical risk factors. But remember that the clinical designations, proximal persistent, often break down inside the in the EP lab when we're looking at the left atrium from inside. With paroxysmal AFib, with normal left LA size and voltage, we still think pulmonary vein isolation, durable, safe with PFA is probably going to do really well. It's going to be safe and maybe move the needle. Persistent AFib, it's all about identifying that additional target. And with PFA, we may be able to better ablate it. And with concomitant AFib and left atrial appendage occlusion, with Watchman and other devices people are using as well, this is going to be a growing population. And Edwin pointed out that it's like TAVR. Maybe you used it in the high-risk patients at first, and then people are going to be walking. A lot of people are going to be walking around with left atrial appendage occlusion devices if this goes really well. But maybe that's a whole other problem, And then there are other alternatives to anticoagulation, right? So maybe stopping the anticoagulation now with better success is an option. There's a study out of South Korea, a lone AFib trial, where they stopped the anticoagulation after a couple of years, even in moderate to high-risk patients with CHAS-2 VAS scores. And so these things will evolve. Maybe use a wearable device to monitor your AFib, and you take pill in the pocket anticoagulation. So these are all in flux and tremendous areas of research, and we have a tremendous team that does this research. Although I just found Kara, this was amazing. There's a lot of there's a lot of food slides in this, and Kara was wearing a shirt that says, food will rule your, it will rule you and just your food, or something like that. So I was just interested in this. So I'll stop there and just see if there's any questions. I'm sorry I kind of rushed through the last part, but I wanted to make sure I covered that. Dr. Katsianis.
Oh, we've got the ceiling.
Oh, thanks. Jade, that was phenomenal talk, and I'm picking up just a little bit of enthusiasm, so thank you. Looking at the field over the last couple decades, we've made positive advances, but they've been increments. This is a leap. This is a real game changer. We all recognize it in the EP lab right away. It kind of makes me think, now that we have this tool, can we get further upstream in the pathophysiology? There was a time that we went after ganglia plexi.
Yeah.
Is there a trigger for the triggers? And are we somewhere that we can start to get towards, I don't want to say primary prevention, but maybe primary and a half, and get way upstream in their disease process?
I think it's a great point, and I think I would agree. If you said, well, now I have a safer tool in the right hands that I can potentially use earlier to do an ablation. And a great example would be the patient we see with a typical flutter, right? They come in with typical flutter, we do a flutter ablation in the right atrium, and then like 50% of them 2 years from then, or in my case, I had a patient the same week who came back with AFib that was never seen before, but they have it. They have concomitant AFib. So maybe we do the AFib ablation, a pulmonary vein isolation at the time we do the typical flutter. Or maybe we take these patients earlier to the EP lab. What's happening now is, because of the efficiency we're doing more procedures, but some of the patients you saw, they're more complex, right? We wouldn't otherwise have taken to the lab. We're able to do it. But you're talking about the other side of things. I very much see that as the future, and being a part of the strategy, like Dr. Chung talked about, or Dr. Benjamin talked about, of preventing progression of AFib. Absolutely.
So maybe to our bigger picture field, maybe putting a patient on their first episode on a beta blocker and waiting is not a good approach.
Yeah, early referral is key, and you saw the way the atria looked. And you may not be able to predict that atrial appearance. So early referral is critical, and I think that will be great data to show, especially with PFA. John?
Jay, amazing talk. Thank you very much. I'm fascinated by the discrepancy between the clinical presentation and the electrical anatomy.
Yeah.
Do you have any information about the long-term follow-up based on electrical anatomy?
Yeah.
And then how do you predict you might change clinical approach and other things?
Yeah, it's a great question. It's one of the questions that we think of a lot as electrophysiologists, because we know that the long-term prognosis of the patients with that electrical disease is very different than the patients with a normal left atrium. And that's why, ideally we get to them early enough that it hasn't progressed that, but that's not always a luxury that we have. So then the question becomes, what is the optimal strategy and technology to prevent that? And it really does require full court press. Now we'll probably have better ablation tools to prevent the sequelae in those patients who come back often with atypical flutters, ATACs, require multiple ablations, because maybe we'll have a tool. We feel strongly that this tool will help prevent, reduce the number of ablations and be more successful. But that's also where the other risk factor optimization, medical therapy, the things that will reduce the remodeling of the atrium adversely, and understanding those factors is going to be key. And we can look at it and outcomes in various different ways. I think that would be
So
very interesting.
in clinic right now, when
Yeah.
I get a patient who comes back from an afibrillation, oh, that's great.
Yeah.
But I don't actually know.
Yes.
And
yes.
so if there is a way to integrate this information and then have a clinical.
I appreciate that. That's very much. It's actually in our notes, but it's maybe not communicated to this degree that we need to be doing as electrophysiologists. I 100% agree. In our notes, you find the hemodynamic data. You find a description of the left atrial substrate. And oftentimes we're looking at modifying them when they leave, but you're absolutely right. If we communicate that better, it's going to be much better on the out. You're going to be able to manage those medications, add the medicines, optimize much better than we are with that one visit after the ablation. So it's a critical point, and it's well received. Absolutely. All right. Tesfa. Yeah.
That was an excellent talk. Thank you so much. One question I have is the prevalence of AFib as of right now is about 10.2 million. It's supposed to be about 12 million by 2030. In terms of the infrastructure that we have and the EP resources that we have, we know that early referral and early ablation can save lives and can save a lot of progression of atrial myopathy and all those bad things. How do you see of access to ablations and infrastructure?
Yeah, this is a critical limitation of our, as with any specialty, right? We have. I think that I was impressed when I reviewed the presentations by Dr. Chung and Dr. Benjamin. There's a lot that can be done for these patients, right, before they come to us. And it really is a full court press. And I think the latest guidelines really touch upon that, how this really starts with their primary care, with their general cardiologist, even before they're referred to an electrophysiologist. They really need to be optimized with modifiable risk factors and a thought process of what's driving their AFib. In terms of, yes, we need more electrophysiologists, we need more advanced practice providers, we need a better team systems to deal with this. But with wearable devices, with increases in technology, there's no doubt that the capacity for ablation procedures has to be increased. Concomitant procedures. In our practice, we anticipate this. Dr. Zashiri and Dr. Kruger are going to come online with these concomitant procedures. So every group has to anticipate this growth and plan accordingly. All right, well, thank you so much for coming.